Recline the patient to a supine or semi-supine position. Preparation also includes an explanation to the patient about the procedure and what they can expect, such as, I'm going to numb your lower teeth and half of your tongue and lip. Before I do, I'm going to use a gel to numb the surface tissue. Once we begin, I will go very slowly to keep you comfortable, so don't be concerned if this takes a few minutes. With the patient's mouth open, begin by identifying critical anatomic landmarks. For these injections, note the anterior border of the ramus and the pterygomandibular raphe. These landmarks will help establish the triangle for the needle entry for the inferior alveolar and lingual blocks. You may palpate these landmarks as well as the coronoid notch. All of this will help locate the underlying inferior alveolar neurovascular bundle and lingula, though you cannot visualize them in your patient. In our virtual setting, let's examine the underlying anatomy. You can see the lingula and the coronoid notch. There is the inferior alveolar neurovascular bundle as it enters the mandibular foramen, behind the lingula. The lingual nerve is seen taking off from the inferior alveolar nerve, just before its entry into the mandible. In giving the injection, your goal is to contact the bone just behind the lingula to achieve the inferior alveolar nerve block. Begin by completely drying the mucosa at the target penetration sites and apply topical anesthetic. You need to wait approximately 1 minute to allow the topical to work. While you wait, turn slightly to assemble your syringe to keep it from the patient's field of view. Retract the tissue at the penetration site with your mouth mirror and ensure that the tissue is taut to allow for a clean penetration of the bevel. Visualize the anatomy and injection triangle. Approach the penetration site while keeping the body of the syringe over the contralateral premolars. Hold your syringe with your palm facing the ceiling. At 6 to 10 millimeters above the occlusal plane, slowly advance the needle into the tissue until you make gentle contact with the bone on the medial aspect of the ramus, and at least half of the needle length is in tissue. If you make bone contact with less than half the needle length in tissue, it is likely that you have made contact with the lingula rather than the medial ramus. To correct this, withdraw partially from the tissue. Slowly redirect the body of the syringe over the central incisors. Repenetrate past the point of previous contact, and then slowly redirect the body of the syringe back to the premolar region, and continue penetrating until you make gentle contact with the medial ramus. Once you have made contact with the ramus, back out 1 millimeter or so, and begin your aspiration sequence. Aspirate, rotate the syringe slightly. Aspirate, rotate the syringe back to the original position, and aspirate a final time. If all 3 aspiration tests are negative, you may begin to deposit your anesthetic solution. If there is a positive aspiration and blood is seen within your anesthetic carpule, withdraw and recap your needle, and replace the carpule with a fresh carpule. Let's take a closer look at the anatomy with the needle in correct position. You can appreciate where the tip should be, and its proximity to the lingula, medial ramus, and the neurovascular bundle. You can see why there is the possibility of a positive aspiration with the nearby vessels. It should take between 1 to 2 minutes to deposit a full carpule of anesthetic solution for patient comfort. Thus, it is necessary for you to be comfortably seated. The most likely cause of discomfort for a patient is the speed with which you penetrate the tissue and deposit the solution. Nothing with anesthetic delivery should be done fast. Once you have deposited the necessary amount of anesthetic, approximately 1/2 to 3/4 of the carpule over 1 minute, Withdraw the needle half the distance of the penetration. Apply a single aspiration test, and if negative, slowly deposit the remaining quarter to a half of the carpule for the lingual nerve block over 20 to 30 seconds. After completing the lingual nerve block, withdraw the entire needle and recap with the one-hand technique. Reload the syringe with a new carpule. Proceed to the buccal nerve block. Approach the penetration site by placing the body of the syringe parallel to the molars, and penetrate at the height of the occlusal plane. Once you have penetrated at least the depth of the needle bevel, approximately 2 millimeters, apply a single aspiration test, and if negative, deliver 1/8 of the carpule of local anesthetic over 20 seconds. Recap the needle using the one-hand technique. Finally, to test whether you've achieved the appropriate areas and depth of anesthesia, ask the patient where he or she is numb by stroking the mucosa or tongue with the back of your Explorer. Compare this to the normal contralateral side. It is important to offer supportive comments to your patient throughout the injection. Avoid words with negative associations, such as hurt, pinch, and shot. Words that are less likely to elicit a negative response include discomfort, pressure, and deliver anesthetic. And remember to provide the patient with post-operative instructions at the end of the procedure.